Hi, welcome back to my channel. Today we're going to be talking about treatments for schizophrenia. This is following up the previous video I did on symptoms of schizophrenia and the theories of schizophrenia. Symptoms and theories. So today we're going to be going over first generation antipsychotics to start, and then I'm going to go through second generation atypicals, and then we're going to talk about what makes them different, what the benefit is of each of them, and then go through the pathway, the go and stop pathway of the nigrostriatal pathway that I talked about in my previous video. So first generation. So one of the most common ones that people know of is haloperidol. Another one is fluphenazine, and then there's chlorpromazine. All these guys are D2 antagonists. Also, sorry if I say a lot. I'm still learning how to do YouTube, and I'm just practicing, and it's a hard habit to break. Anyway, so all of these guys are D2 antagonists, and an antagonist is something that when it binds to a receptor, it basically prevents the actions of the agonist. So it does not mean that it blocks all constitutive action. That's an inverse agonist. An antagonist is also sometimes called a silent antagonist because it basically just brings the neuron back down to its baseline constitutive action level. So whereas an antagonist is going to ramp up the action of the neuron, and then a partial agonist is going to do either have an antagonistic action or an agonistic action dependent on the environment in which the partial agonist is placed. So haloperidol, fluphenazine, and chlorpromazine are all D2 antagonists, which means that they block dopamine from binding to D2 receptors, and this is mostly taking place in the mesolimbic pathway, but it also takes place anywhere there's a D2 receptor, and this is why side effects do exist for these medications, and side effects exist in general, because I've said it before and I'll say it again. It's like, if any of you guys have Labradors at home, then you'll know that Labrador retrievers, the type of dog, love food, and if you put food all over the floor, the lab is going to go munch it up. It's going to go lick up the food in all the places. It's not going to say, oh, well, there's food in my bowl and that's the only food I eat. And that's like a medication for schizophrenia. It's not just going to target the D2 receptors in the mesolimbic pathway. It's also going to target the D2 receptors anywhere there's a D2 receptor in the brain. And the main goal of these medications is to treat the positive symptoms associated with schizophrenia. So this includes stopping the delusions and hallucinations and anything else that is a positive symptom. And then some of the side effects that are most commonly noted are DIP, and then eventually tardive dyskinesia can occur if DIP is not, or if the medication is taken over a long period of time. Let's go through why this happens. So here we see in this tardive dyskinesia, the DIP has to do with the nigrostriatal pathway. So in the nigrostriatal pathway, you have the substantia nigra, and this is the first component. And in the substantia nigra, there's vesicles with these enzymes on them called VMAT2, which are vesicular monoamine transporters, and these pump dopamine back up into the vesicle so that it can be released into the synaptic cleft and then do downstream signaling. These vesicles right here are dopamine, and as shown in this picture, they are fusing with the presynaptic membrane and dumping into the synaptic cleft. This DAT is a dopamine reuptake pump that pumps dopamine out of the synapse into the presynaptic axon terminal. Normally, when dopamine is released, it binds to a receptor. In this case, this is a D2 receptor. When it binds to the D2 receptor, or D3, they're both inhibitory, it inhibits the firing of the next, or the postsynaptic neuron. In this case, in the ventral striatum, it's a GABA neuron. So if it inhibits GABA. So that means that there is inhibition of GABA production. So this means low GABA. Now, if there's a D2 antagonist given, it's going to block dopamine from being able to bind which is going to cause GABA not to be inhibited, or the disinhibition of the inhibitor. And this is going to result in GABA becoming higher. So now we're going to have high levels of GABA in the ventral striatum, because dopamine is not going to be able to bind to the D2 receptors. A chronic blockade of these receptors, so here we have lots of dopamine building up in the cleft, it's going to result in the upregulation. So more receptors are going to be pushed up to the surface, and these new receptors are going to be sensitive, because the cell or the neuron is going to be like, yo, where's the signal from the dopamine? All we get is high GABA. Where's low GABA? We're not getting the signal, so she's going to adapt. So initially, when you have just these, this blockade here, we're going to have to go over here to understand how this works. So this looks really complicated and confusing, and honestly, it kind of is, but we're going to get through this. So here's the prefrontal cortex. The red is the glutamate, and the blue is the GABA. So it talks to the substantia nigra, that's the SN right here, through a GABA. So here's substantia nigra. Okay. So we have a dopamine in our neuron. This is a dopamine. And then we have a GABA, another GABA, a glutamate, a GABA, another glutamate, and then we have the motor cortex. So let me break it down for you. So first, let's just go baseline. So dopamine is released onto this right here, this GABA. Now this is this. So let's look at these side by side. These are the same. So this substantia nigra is this substantia nigra, and this presynaptic dopamine is this one here, and then this postsynaptic GABA is this one here. So we have dopamine coming in and binding to the D2 receptors, which is going to cause inhibition of GABA. So this is going to result in low GABA. We went on up to the globus pallidus 1. Globus pallidus, if you have low GABA, it's not going to be inhibiting the next GABA, so there's going to be high GABA. If we have high GABA, this is going to inhibit the subthalamic nucleus glutamate, so this is going to be low glutamate. Low glutamate is not going to stimulate the GABA in the globus pallidus 2. So now you're going to have low GABA. And then low GABA means it's not going to be inhibiting the next glutamate, so you're going to have high glutamate. And when you have high glutamate, you have the go pathway initiated. And so now we're going to go. So it's go pathway and you're moving. And so this is what happens under normal conditions when dopamine is released. Now, let's roll the tapes back. Just try to erase this stuff. Okay. If dopamine is prevented from binding because we have something going on like this, what did we say over here? If you block dopamine from binding, there's no inhibition, so you have high GABA. So now coming over here, we're going to have high GABA. High GABA, it's high inhibition, so this next one's going to be low GABA. Low GABA means not very inhibited, so this is going to be high glutamate. High glutamate is going to stimulate the next neuron, so it's going to be high GABA. High GABA is going to inhibit the next one, so it's going to be low glutamate. So this is going to be the stop pathway, or the inhibition of the go pathway. And this is why, if you give a D2 antagonist, you could have drug-induced Parkinsonism, also known as DIP, because you're going to have an overactivation of the stop pathway, so this is going to cause tremors. Now, what can happen is if you do this too long, you have a chronic blockade, the cell adapts. As I said before, you have this adaptation, you have an increase in upregulation. plus increase in sensitivity of the D2 receptors. And then this can lead to any dopamine that gets out here will be able to bind here. And this is going to cause something called tardive dyskinesia, which is excessive or hyperactive movement that's uncontrolled. And for a lot of these people that develop this condition, it's permanent. And once you have this upregulation of the receptors and increase in sensitivity, you cannot the receptors will not go away, because now they're searching, because any dopamine they get, they're going to bind and they're going to inhibit GABA, and then you're going to have excessive movement. So this is really debilitating for people. So the treatment for this is giving a VMAT2 inhibitor. So if you inhibit VMAT2, dopamine cannot get packaged, so it's not able to fuse and release. So lower dopamine, and high dopamine levels is what causes the go pathway. So, so that's why you would do that. But these drugs do work really well to block the positive symptoms, because they bind D2 super well. I think, do I have a picture here? Yeah, here we go. So they bind, oh shoot, I was in my other one. But they bind, where is it? This one right here. In the mesolimbic pathway, this is where the positive symptoms occur. These drugs will get in here and block dopamine from binding, so that there is no inhibition of GABA. So then GABA's high, and that will high GABA will inhibit downstream effects. So this will inhibit positive symptoms. So this is why they're so useful, because they work through the mesolimbic pathway to decrease the positive symptoms. However, a drawback to these types of medications is that, as I said before, it's not limited to the mesolimbic pathway. So we're also going to be blocking dopamine in other areas of the brain. And as stated, the mesocortical pathway loves dopamine. This pathway doesn't have any dopamine reuptake pumps. And if you have low dopamine, which you already have, if someone has schizophrenia, they already have lower dopamine in this pathway, then giving a medication that's a D2 antagonist is going to block any of the signaling that any of the remaining dopamine was going to do. So this will actually result in patients becoming having even worse negative symptoms, having even worse cognitive symptoms and affective symptoms. So this is why it's important to really, you have to weigh the pros and cons. And I'm not a doctor, I'm not a psychiatrist, but a provider will have to look out for symptoms of tardive dyskinesia, symptoms of worsening secondary side effects from treatment. So because first-gen antipsychotics don't work for everyone. Oh, and this is a summary right here of the stop pathway and the go pathway. This just walks it through. So if you want to pause the video here, me acting like I have viewers, pause the video here, and then you can just look through this and see. I just drew out the pathways and wrote what was going on at each step, because I feel like it's useful. To be completely honest, it took me probably at least a month to understand this. I mean, okay, I understood it, but being able to do it from memory is really hard, and also I always forget and I had to go back. But that's what the reviews are for. So yeah, okay. Now we're talking about second-gen antipsychotics. So we've identified that there are problems with the first gen, namely that they cause increase in secondary side effects, and they also can cause tardive dyskinesia, dip, and then tardive dyskinesia if continued long-term. So let's talk about some other options. We have olanzapine here. Olanzapine, I like to think of olanzapine as, it's she's kind of doing a lot of things. She's O blood type, O can give to anyone, O negative at least. She's doing everything. She's doing schizophrenia, she's doing bipolar, she's doing major depressive disorder. She has her toes in everything. She's dipping in. So olanzapine is a 5-HT2A and D2 antagonist, but it's not as strong of a D2 antagonist as our first gens, our typical antipsychotics. So this is why it has less side effects, or it's supposed to have like less side effects in terms of like negative affective and cognitive symptoms. But it does have an increased risk of weight gain and drowsiness because of the H1 antagonism and histamine, the H1 receptor, when it's agonized, I guess, by the histamine molecule, it promotes like wakefulness and growth and other things like that. So, and it also has, olanzapine also has 5-HT2C antagonism, and this one is involved with metabolic changes, and this one's also antagonized by Prozac. And this is why you have to be careful when giving olanzapine, because when given with Prozac, it can cause pretty intense weight gain. So, but you also have to understand that Prozac is approved with olanzapine for major depressive disorder and also bipolar depression. Because olanzapine is not just given for schizophrenia, it's given for a lot of things. So you might be wondering, like, well, why the heck would you even want 5-HT2A to be antagonized? Well, because if you remember in my previous video about schizophrenia, 5-HT2A was a receptor that allows for the activation of the glutamate, the second glutamate neuron in the whole glutamate chain. And normally at like baseline, if someone doesn't have schizophrenia, then the stimulation, the excitation of the glutamate neuron from the serotonin, from the Raphi nucleus, will promote like normal signaling. But if someone doesn't have inhibition from GABA, then this is going to lead to overexcitation, this receptor up here. So blocking it with an antagonist will actually increase inhibition, and then this will lower the levels of glutamate. So you have lower glutamate, and this is beneficial because this means lower glutamate means lower GABA, so because it's not going to stimulate as much. And in the mesocortical pathway, that means higher dopamine, and this helps to alleviate a lot of the secondary secondary side effects, and also just negative symptoms and cognitive symptoms and affective symptoms that arise from the mesocortical pathway. So that's why 5-HT2A receptors are beneficial, and you still have that D2 antagonist effect, which will help with controlling positive symptoms. Not as good as the first gens because it's not as strong, but it leads to less problems with DIP and TD. So, and then we also have clonazepam. This one is very similar to olanzapine in the sense that it's both a 5-HT2A receptor, 5-HT2A and D2 antagonist, but it's also a alpha-1 antagonist, which can cause low blood pressure because alpha adrenergic receptors cause high BP. So when you antagonize them, you have low BP, you can feel dizzy, you can feel drowsy. And then the last one, which is really like the queen of everything. Oh, wait. I forgot one more thing. Olanzapine and clonazepam, these guys also are really useful in getting rid of the breast milk production that can occur with typical antipsychotics, because up here, they're antagonizing D2, and in my previous video I talked about how if you dopamine normally inhibits prolactin secretion, but if you inhibit dopamine from binding to its inhibitory receptors, then you're going to have the stimulation of prolactin that can cause breast milk production in both biological males and females. But if you give a 5-HT2A antagonist, you're going to be blocking both the dopamine from binding, but you're also going to be blocking the stimulatory molecule, which is serotonin, from binding. So you're going to be blocking both. So you're going to be inhibiting and what's the word opposite of inhibiting? Inhibit and exciting the opposite receptors. So then that will allow for you to not have abnormal prolactin levels. So that's why these guys are good, the secondaries. Oh, wait, where did they go? Here we are. Okay, and then finally, cariprazine. This is a D2 5-HT1A partial agonist. And partial agonists are so fun because they're just different. Partial agonists have way less, not way less, but partial agonist is not going to bind to the D2 receptor with as much strength as even olanzapine and clozapine, and it's also going to be really useful for people that experience drug-induced Parkinsonism or even just tremors from schizophrenia, because it's going to allow for a lot more dopamine binding. So it's not going to do as good of a job at controlling the positive symptoms, but it will help because it has this 5-HT1A portion, and these 5-HT1A serotonin receptors are present on the axon of this second glutamatergic pyramidal neuron. And so if you bind with a partial agonist here, it's going to act as an agonist, and it's going to activate. And these receptors are normally inhibitory, so it's going to inhibit glutamate. So it's going to lower glutamate, which will in turn, as we talked about before, lower the amount of GABA to the mesocortical pathway, increase the amount of dopamine present in the DLPFC and the VMPFC to help with side effects. So that's why cariprazine is a good option, especially when used to treat or to alleviate the symptoms of DIP. So yeah, these are all the medications that I covered in my class for schizophrenia, and this is pretty much the content. But if you guys have any other things you want to learn about or any other medications, I'm super down to learn more medications for schizophrenia. Normally I know it's not just like one medication that is given for patients with schizophrenia. There's a whole combination of things, but in terms of controlling the positive symptoms, these are really the medications